Bismillahirrahmanirrahim. Today we are going to learn about Hodgkin lymphoma. Following are the references for this video. The learning objectives for Hodgkin lymphoma: at the end of this lecture, the third year MBBS student should be able to describe Hodgkin lymphoma and its pathogenesis, elaborate its clinical feature, evaluate the hematological and biochemical findings, explain its management and treatment. So we will find the pathology that is behind this case scenario, where a 22-year-old man present to your office complaining of a painless lump in his neck. Upon further questioning, you discover that he has had a low-grade fever and drenching night sweat for the past 2 months. The physical examination revealed unilateral cervical lymphadenopathy and splenomegaly, and lymph node biopsy revealed large multinucleated cells with prominent nuclei that resemble owl's eye. Though there is clear distinction between the lymphoma and leukemia, but sometimes these terms may be confusing, or clinical presentation may confuse the physician. So leukemia is the neoplasm that present with widespread involvement of the bone marrow and the peripheral blood, while lymphoma is the proliferation that arises as discrete soft tissue mass. But many entities that are called lymphoma, they may have leukemic presentation, or evolution to leukemia is not unusual when a lymphoma progresses, or tumor identical to leukemias arise as soft tissue mass that doesn't show any accompanying bone marrow disease. So when applied to a particular neoplasm, these two terms, the lymphoma and leukemia, they merely reflect the tissue distribution of the disease at the time of presentation. Lymphoma, more commonly the solid tissues, and the leukemia, the liquid malignancy. So we can define lymphoma as the neoplastic lymphoid proliferation that arises as a discrete soft tissue mass, and it is a generic term that is given to the tumor of the lymphoid system, and specifically to the lymphocyte and their precursor cell, whether of T, B or null phenotype. Since decades, this lymphoma is a problem for pathologists for the diagnosis and for physician for its management. There is famous sentence from the Pathology of Tumors by Willis that he stated, "Nowhere in pathology has a chaos of name clouded clear concept as in the subject of lymphoid tumors." The current WHO classification has divided lymphomas into 5 major categories: the precursor B cell neoplasm, that are the neoplasms of the immature B cells; peripheral B cell neoplasm, that are neoplasm of mature B cells; precursor T cell neoplasm, that are neoplasm of immature T cell; and peripheral T cell and NK cell neoplasm, that are neoplasm of the mature T cells and NK cells. Today we are going to learn about the Hodgkin lymphoma, that are the neoplasm of the Reed-Sternberg cells and variants. The majority of the lymphomas are of non-Hodgkin variety and includes B cell tumor, T cell tumors and natural killer cell lymphomas, and only 15% of the lymphomas are of Hodgkin variety. The Hodgkin lymphoma was formerly known as Hodgkin disease, and it was first described by Dr. Thomas Hodgkin in 1832, who worked at Guy's Hospital, London. He described distinctive features of this disease, and this is a neoplasm of B lymphocytes and has got large pleomorphic prominent nucleus in a halo, and these cells are then termed as Hodgkin cells. And this disease is treated in a unique fashion. The current WHO classification of this disease is a type of malignant lymphoma in which Reed-Sternberg cells are present in a characteristic background of reactive inflammatory cells of various types, accompanied by fibrosis of a variable degree. So the Reed-Sternberg cell, inflammatory cells and fibrosis. Three important things to remember in the definition of this Hodgkin lymphoma. Hodgkin lymphoma has got some characteristics that differentiate it from non-Hodgkin lymphoma. It more often localized to a single group of the lymph nodes that may be cervical, mediastinal or para-aortic, while the non-Hodgkin lymphoma more frequently involve multiple peripheral nodes. The Hodgkin lymphoma spreads in contiguity, while spread in non-Hodgkin lymphoma is non-contiguous. Then the Hodgkin lymphoma, the mesenteric nodes and Waldensian rings are rarely involved, while there is frequent involvement of this Waldensian ring and mesenteric nodes in non-Hodgkin lymphoma. The extranodal presentation is rare in Hodgkin lymphoma, while it is common in non-Hodgkin lymphoma. The Hodgkin lymphoma is characterized by presence of Reed-Sternberg cell that was described by Sternberg and Reed in 1898 and 1902 respectively, and vast majority of these Hodgkin lymphomas, the Reed-Sternberg cell derive from germinal center or post-germinal center B cells. These cells release factors that lead to accumulation of reactive lymphocyte, macrophages and granulocyte, and these inflammatory cells make up more than 90% of the tumor cellularity. This is the characteristic picture of the histological picture of the Reed-Sternberg cell, the all-eye appearance of the Reed-Sternberg cell with two nuclei and prominent nucleoli with a clear halo around it. So for right now, just remember this, and we are going to see various variant and detailed histology of these Hodgkin cells or Reed-Sternberg cells. Now the epidemiology of this disease, it is 0.7% of all new cancers in the USA. About 8,000 new cases per year are diagnosed. That comprises about 3 per 100,000. Then average age at HD diagnosis is 32 years. It is the most common cancer of young adult and adolescent. Can occur any age between the age of 10 to 30 years usually, and it is more common in men than in women. It was the first human cancer to be successfully treated with radiation therapy and chemotherapy. And if treated properly, it is curable in most cases. So this picture, this histopathology slide is showing the characteristic feature of a Reed-Sternberg cell that is lying in a background of many inflammatory cells. This classical or typical RS cell, Reed-Sternberg cell, has got amphophilic cytoplasm, two nuclei that are mirror image to each another, and there is prominent eosinophilic nucleoli. So as we know, the origin of Reed-Sternberg cell is the germinal center or post-germinal center B cells, and B cells, as we know, they are responsible to secrete immunoglobulin, but here they do not produce immunoglobulin because there are genetic rearrangements that have occurred, and they are responsible for this. So the activation of nuclear factor kappa B is the main event that lead to growth and survival of these Reed-Sternberg cell, and this can be activated by viral, immune or familial causes, and the one of the viral cause is Epstein-Barr virus that has got a latent membrane protein 1, and it is responsible for activation of the nuclear factor B, while the loss of function mutations are there in the non-viral causes or non-EBV cases of the Hodgkin lymphoma, and these include inhibitory kappa B and TNF alpha induced protein 3. Loss of function of both these that are the regulator of negative regulator of nuclear factor kappa B are responsible for growth and survival of these Reed-Sternberg cell. So main step in the pathogenesis is activation of nuclear factor kappa B. The Reed-Sternberg cells show aneuploidy, and there may be copy number gains in real proto-oncogenes that are present in chromosome number 2 short arm, or program death ligand 1 and program death ligand 2 that are present on chromosome number 9, the short arm of the chromosome number 9. The real proto-oncogene is responsible for activation of nuclear factor kappa B, while PDL1 and 2 inhibit anti-tumor T cell response. Any of this mechanism that lead to development of Reed-Sternberg cell, and there is release of cytokines and chemokine. Cytokines such as interleukin 5, interleukin 10, and macrophage colony stimulating factor, and chemokines, one important is eotaxin. And when these are liberated in that environment, there is accumulation and recruitment of the reactive cells, reactive inflammatory cells, and these are responsible responsible due to release of various cytokines and factors. They are responsible for the growth and survival of this Reed-Sternberg cell. Now, the series of events that lead to the formation of this Reed-Sternberg cell are like these. When there is a germinal center B cell, it is transformed due to any event that can be familial or non-familial, viral or other. It forms a Reed-Sternberg cell that has got characteristic morphology, the classical one we have just discussed, and then this exhibit loss of apoptosis, release of various cytokines, and they are responsible for recruitment of inflammatory response and the development of inflammatory response and recruitment of inflammatory cell in that area. This Reed-Sternberg cell is an active cell, and it is continuously in crosstalk with the cells that are present in its surrounding, and it does so by expressing many receptors and secreting many cytokines or chemokines that that do this function, that perform this crosstalk. One is macrophage colony stimulating factor that is responsible for monocyte macrophage infiltration or activation. There is expression of interleukin 13 receptor that is activated by interleukin 13, that is also secreted by this Reed-Sternberg cell. Then there is expression of hepatocyte c-Met protein that binds with the hepatocyte growth factor, and it recruits dendritic cells. Then CD40 is also expressed on this, and it is responsible for enhanced T helper 2 response. The tumor necrotic factor alpha and beta fibroblast growth factor are responsible for fibrosis, and CD30 is also expressed. Interleukin 5 is responsible for tissue eosinophilia. Galectin and various chemokines are responsible for enhanced T regulatory response, and program death ligand 1 is also expressed that bind with the program death receptor of the cytotoxic T cell, and the interleukin 10 also blocks this T helper 1 response, and these suppress T helper 1 and cytotoxic T cell response. So this by this mechanism it increases its longevity. Many associated factors for the development of Hodgkin lymphoma have already been described. We have also discussed the role of Epstein-Barr virus infection. Some of the diseases, some of the Hodgkin lymphoma are associated with history of infectious mononucleosis. The disease is common in a smaller family size, higher socioeconomic status, It is more prevalent in Caucasian than that of non-Caucasian. There is some link with the genetic predisposition, and other causes are also, other etiological factors are also known, such as HIV, occupation, and herbicides use. Grossly, the lymph nodes are enlarged and the consistency may be soft to hard. This depends on the degree of the fibrosis. Then there is some degree of nodularity that is always there, and foci of necrosis may be present on cut section. The lymph node shows heterogeneous appearance. This is the cut surface of a lymph node that is affected by Hodgkin lymphoma, and here you can see that the cut surface is heterogeneous and also showing some areas of fibrosis, and hemorrhage is also evident. This picture is also showing a closer view of a lymph node that is affected by Hodgkin lymphoma. Here you can see that the cut surface of this lymph node is thrown into numerous small areas, and this is the nodular appearance of this cut surface. The red brown areas, red brown discolored areas, are the areas of necrosis, while the surrounding capsule is thickened. The Reed-Sternberg cell or its variant is essential for the diagnosis of Hodgkin lymphoma. The Reed-Sternberg cell is a large cell, giant cell, and has got size of more than 45 micron in diameter. The cytoplasm is abundant and amphiphilic. Nuclei can be multiple or single nucleus with multiple nuclear lobes. Nucleolus has got large inclusion-like appearance, and it is about the size of a small lymphocyte, about 5 to 7 micron in diameter. One variant of this Hodgkin lymphoma cell or Reed-Sternberg cell is a mononuclear variant. It has got a single nucleus with large inclusion like nucleolus. The lacunar variant is named so because the nuclei, they appear lying in a lacunae or hole. It is seen in nodular sclerosis subtype, and nuclei are more delicate, folded or multilobate. There is abundant pale cytoplasm, and this is disrupted during the cutting of the section and leave a space behind that is an empty hole, and this is termed lacuna and responsible for the name of this lacunar variant. Another variety is lymphohistiocytic variety, and this is present in lymphocyte predominant subtype, and the nuclei are polyploid in this variety. The nucleoli are inconspicuous and cytoplasm is abundant. In classic Hodgkin lymphoma, the Reed-Sternberg cell undergo cell death, in which there is shrinkage of the cell, the cytoplasm is deeply stained, and it becomes pycnotic, and this is termed as mummification. This illustration is summarizing the various type of Reed-Sternberg cell we have just discussed. The Reed-Sternberg type of the cells are also present in infectious mononucleosis, solid tissue tumors, and large cell non-Hodgkin lymphomas. So they should be differentiated by these entities. The diagnosis of Hodgkin lymphoma depends on presence of Reed-Sternberg cell, non-neoplastic inflammatory cells, and characteristic immunohistochemical profile. These photomicrographs are showing the Reed-Sternberg cell or Reed-Sternberg-like cells that are present in malignant melanoma or osteoblastoma. Now the subclasses of Hodgkin lymphoma. There have been many attempts in the categorization or classification of the Hodgkin lymphomas. The Jackson and Parkins classification of 1947 was one of them, and it divided this disease into three varieties, that are granuloma, paragranuloma, and sarcoma variants. But due to this classification, about 80% of this Hodgkin lymphoma variety, they fell into the granuloma type. Then the Smetana and Cohen, they introduced the term sclerosing type of Hodgkin disease in 1956. Then Lukes et al. In 1963, they described the six varieties of this Hodgkin disease, that are lymphocytic and histiocytic, LNH diffuse, and nodular sclerosis, mixed cellularity, diffuse fibrosis, and reticular. In Rice Conference on Hodgkin lymphoma in 1966, they divided this Hodgkin disease into four variants, that are nodular sclerosis, lymphocyte predominance, lymphocyte depletion, and mixed cellularity. The current classification, current WHO classification of this Hodgkin lymphoma divides the Hodgkin lymphoma into five categories, that are nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion, and fifth one is nodular lymphocyte predominance. The first four come under the classical form of Hodgkin lymphoma, while the fifth one, the nodular lymphocytic predominance, is non-classical one. The most common type of the Hodgkin lymphoma is nodular sclerosis type, and it comprises about 65 to 70% of the cases. This type is characterized by presence of lacunar variant of Reed-Sternberg cell, and there is deposition of abundant collagen that are present in bands, and they divide the lymph node into circumscribed nodules. There is a presence of fibrosis that can be scant or abundant. The Reed-Sternberg cells in the background of T cells, eosinophils, plasma cells, and macrophages are there, and the diagnostic Reed-Sternberg cell may often uncommon. So this is a low power view of Hodgkin lymphoma. You can see there are presence of acellular fibrous bands of collagen that are separating or differentiating this lymph node into nodules, small nodules. So this is nodular sclerosis type of Hodgkin lymphoma. As we have pointed out earlier, that this nodular sclerosis type is associated with lacunar variant. So here you can see that there is presence of these lacunar variant, lacunar cells, Reed-Sternberg cell of lacunar variety, that are present in the nodular sclerosis type. This is another photomicrograph that is showing that there are many lacunar cells that are present in the background of inflammatory cells. As we have seen in the diagnostic criteria for Hodgkin lymphoma, the immunohistochemical profile is important, and it is specific for both the classical and non-classical types of Hodgkin lymphoma. The classical type of Hodgkin lymphoma, in all four types of classical type, there is positive PEX5, and that this PEX5 is a B cells transcription factor, CD15 and CD13. So PEX5, CD15 and CD30 are positive, while other B cell markers such as IgM, CD19, T cell marker, and CD45 are negative in classical in the classical type of Hodgkin lymphoma. This is CD30 immunostain for the Hodgkin lymphoma, and here you can see that Reed-Sternberg cell is positive. This positivity is present in more than 90% of the cases of Hodgkin disease. So this is another picture that is showing CD30 immunopositivity in a Reed-Sternberg cell. LMP1 antigen can also be localized by using immunohistochemical stain, and it is present in EBV positive cases. So the classical variety is associated with positivity of CD30, CD15 or EBV latent membrane protein, while CD45 is negative in classical variety of Hodgkin lymphoma. This nodular sclerosis type is about equally common in both male and female, and it usually affects adolescent or younger adult. The lower cervical, supraclavicular, and mediastinal lymph nodes are the lymph node groups that are affected most, and the prognosis of this entity is excellent. The mixed cellularity type of Hodgkin lymphoma comprises about 20 to 25% of the cases. The architecture of the lymph node is diffusely effaced by cellular infiltrate comprised of T cell, eosinophils, plasma cells, and benign macrophages that are admixed with the Reed-Sternberg cell. The diagnostic Reed-Sternberg cell, classical Reed-Sternberg cell, and mononuclear variants are present in this mixed cellular variety, but lacunar variants are also seen. Then the immunophenotype is identical to the classical Hodgkin lymphoma. This photomicrograph is showing numerous classical Reed-Sternberg cell that are present in the background of a polymorphic lymphoid infiltrate, and this is the mummified Reed-Sternberg cell. This mixed cellularity type of Hodgkin lymphoma is more common in males, and it affects older age group. The systemic symptoms such as night sweat and weight loss are more common, and advanced tumor stage is usually this disease is diagnosed at advanced tumor stage, and overall prognosis of this mixed cellularity Hodgkin lymphoma is very good. The lymphocyte-rich type of Hodgkin lymphoma is an uncommon form, and there is presence of reactive lymphocytes that make up the majority of the cellular infiltrate. Then the involved lymph nodes are effaced diffusely, but vague nodularity may be seen with the presence of residual B cell follicles. This lymphocyte rich should be differentiated from lymphocyte predominant type of the Hodgkin lymphoma, that is of non-classic type. So this lymphocyte rich type, that is classical one, is associated with Reed-Sternberg cells that are classic or mononuclear variant. The immunohistochemical profile of this lymphocyte rich type is of classical variety, and it is associated with Epstein-Barr virus in 40% of the cases, and the prognosis is very good to excellent. The lymphocyte depletion type is the least common variety, and it is common in less than 5% of the cases. There is absence of lymphocyte with presence of abundance of Reed-Sternberg cell or their pleomorphic variant. The immunoprofile is of classical variety, and more than 90% of the cases are associated with Epstein-Barr virus. So immunohistochemistry or immune profile is very important in the Hodgkin lymphoma. Then most tumors suspected of being lymphocyte depletion variety of Hodgkin lymphoma, they actually prove to be large cell non-Hodgkin lymphomas. The lymphocyte depletion type of the Hodgkin lymphoma most frequently affect elderly, and it also affects HIV individuals of any age. It is common in non-industrialized countries and associated with advanced stage and systemic symptoms. The prognosis is less favorable than in other subtypes. Now just recall the morphology of the Reed-Sternberg cell and the association of or presence of these Reed-Sternberg cell in a specific variety of Hodgkin lymphoma. All of these are of classic variety, and they are associated with CD30, CD15 B cell marker, and in some cases Epstein-Barr virus, LMP or latent membrane protein is also positive. The fifth and non-classical variety of Hodgkin lymphoma is nodular lymphocyte predominance type, and it is uncommon variant that is present in 5% of the cases, and the involved lymph nodes are affected by presence of nodular infiltrate of small lymphocytes that are mixed with macrophages. The nodular lymphocyte predominance variety is associated with LNH variant of the Reed-Sternberg cell that have got multi-lobed nucleus that resemble a popcorn kernel, hence they are termed as popcorn cells. The eosinophils and plasma cells in these nodular lymphocyte predominance type are absent. The low power view is showing the mottled appearance of this lymph node, while on high power you can see that there is a presence of popcorn cell. So this is the LNH variety of Reed-Sternberg cell lymphocyte and histiocyte predominance type of Reed-Sternberg cell. The nodular lymphocyte predominance type is positive for CD20 and BCL6, while negative for CD15 and 30. The CD15 and 30 were positive in the classical type. Then it has also got nodular growth pattern. There is presence of expanded B cell follicle that are populated with LNH variant and numerous reactive B cells and follicular dendritic cells. There is IGH gene somatic hypermutation that occur only in the germinal center B cells. 3 to 5% of this nodular lymphocyte predominance variety, they go towards the DLBCL, diffuse large B cell lymphoma. Then this disease, this fifth non-classical variety, nodular lymphocytic predominance type of Hodgkin lymphoma, is not associated with Epstein-Barr virus. This nodular lymphocyte predominance variety affect males less than 35 years of age and affect cervical or axillary lymph node most. However, mediastinal lymph node and bone marrow involvement is also there, but it is rare. Recurrence is likely and it has got excellent prognosis. Besides these diagnostic features, the Hodgkin lymphoma may show a variety of features that obscure the diagnosis. One of these is presence of sarcoid-like granuloma formation. This photomicrograph is showing the invasion of the vessel by this Hodgkin lymphoma. The patient of the Hodgkin lymphoma usually present with the lymph node enlargement, and like the scenario we discussed in the start of this lecture, the supraclavicular lymph node or the anterior cervical chain of the lymph node is affected. The presenting feature of the Hodgkin lymphoma may be localized non-tender lymph node enlargement, and the lymph nodes involved are neck and supraclavicular area, mediastinal lymph node, or other abdominal or extranodal sites. Then there is presence of systemic symptoms such as fever, night sweat, and unexplained weight loss that can go up to 10% over the last 6 months. Other symptoms for this Hodgkin lymphoma are fatigue, weakness, pruritus, cough, chest pain, shortness of breath, vena cava syndrome, abdominal pain, bowel disturbances, ascites, and bone pain. So the lymphadenopathy is the presenting complaint of about 90% of the patients, while mediastinal mass 60% of the patient. These symptoms are present in 30% of the cases, and the patient that present with hepatosplenomegaly comprise of 25% of the patient. The commonly involved lymph nodes are cervical and supraclavicular in 75% of the cases, and only 5% of the cases are associated with involvement of bone marrow. A variety of skin disorders are associated with this Hodgkin lymphoma. Some of these are ichthyosis, acrokeratosis, or basic syndrome, tricharia, erythema multiforme, erythema nodosum, necrotizing lesion, hyperpigmentation of the skin, or skin infiltration by the tumor cells. This picture is showing ichthyosis. That means the fishy skin or fish-like appearance of the skin. Another feature is acrokeratosis, that is the hyperkeratosis of the acral parts. Development of tricharia, the presence of lesions of erythema nodosum, hyperpigmentation of the skin. Then Hodgkin lymphoma is also associated with nephrotic syndrome due to paraneoplastic effect, and this paraneoplastic effect is due to secretion of interleukin 13, and it happens in the early stage of the Hodgkin lymphoma. The pathological pattern of the disease are minimal change disease and focal glomerulosclerosis. The neurological symptoms are cerebellar degeneration, chorea, neuromyotonia, limbic encephalitis, subacute sensory neuronopathy, and subacute lower motor neuronopathy. Now, many tests are done to diagnose this disease. CBC is the first basic test that reveals anemia, normocytic, normochromic type, and eosinophilia, neutrophilia, and with lymphopenia. ESR is raised, and LFTs are disturbed when there is liver infiltrate presence or there is obstruction at porta hepatis. The renal function tests are done prior to the treatment for the to get a base value. Urate and calcium are also increased. LDH is this is a marker of adverse prognosis, lactate dehydrogenase. The imaging techniques such as X-ray chest shows a mediastinal mass, or the CT scan of the thorax, abdomen, and pelvis are done for the staging of the disease. Other imaging techniques are gallium scan, PET scan, lymphangiography, and laparotomy is also done for the staging sometimes. The Hodgkin lymphoma spreads by direct extension to other lymph node group or lymph node, and then it goes to spleen, liver, and bone marrow. It spreads by contiguity, that means it first affects a lymph node or group of a lymph node, then goes to spleen, liver, and then bone marrow. It may affect practically any other organ within the body, and secondaries may be present in lung, skin, JIT, and CNS. So this Hodgkin lymphoma is staged on according to its extent in 4 stages. Stage 1 is involvement of a single lymph node region and termed as 1, or when the extralymphatic site is involved, that is termed as stage 1E. When 2 or more lymph node groups are affected, it is termed as stage 2, and when an extra lymph node or extralymphatic organ site and 1 or more lymph nodes are affected, and these are present on one side of the diaphragm, it is 2E. It is stage 3 when it is affecting both sides of the diaphragm, and when affecting spleen, it is termed as 3S. When it is also associated with involvement of extralymphatic organ or site, it is 3E, or when the spleen and extralymphatic site both are involved, it is 3SE. The diffuse or disseminated involvement of one or more lymphatic and extralymphatic site is termed at stage 4. This picture is describing the staging of the Hodgkin lymphoma from stage 1 to stage 4. Stage 1 is confined to one group of the lymph node, while stage 2 is affecting more than one lymph node group, but these are located on one side of the diaphragm, and stage 3 is affecting both sides of the diaphragm. Stage 4 is the disseminated disease. This Hodgkin lymphoma has got a good cure rate for stage 1 and 2, and it is about 90%, while 5-year survival rate for stage 4 is 60 to 70%. Unfavorable prognostic factors are stage 3, B or 4, then presence of B symptom, bulky disease, and ESR that is more than 50. This is the gross cut section of the spleen that is showing the replacement of the spleen parenchyma by these grayish white nodules. These are multiple, and these are present throughout the spleen parenchyma, and this pattern is usually present in Hodgkin lymphoma and non-Hodgkin lymphoma. In this particular case, this was of Hodgkin disease that was proved histologically. The diffuse involvement of the spleen is seen in leukemic involvement and extramedullary hematopoiesis. So this liver is the gross specimen of the liver is studied by numerous nodules, and this is the metastasis by the Hodgkin disease. It is very important to stage this Hodgkin lymphoma to decide the treatment. This is the CT image of the Hodgkin lymphoma. This abdominal CT is showing involvement of the spleen by attenuated mass lesion that is presenting extranodal involvement by the Hodgkin lymphoma. There is also the prominent lymphadenopathy that is marked by this rhomboid red mark, while the spleen is marked by this triangle. Stanford and Hope, they studied a series of Hodgkin lymphoma and determined the cause of death. The Hodgkin lymphoma per se is the cause of death in 41.2% of the cases, while development of secondary cancer due to treatment due to radiotherapy and chemotherapy, it was the cause of death in 21% of the cases. Cardiovascular causes were third most common causes that were present in 15.9% of the cases. So about more than three-quarters of the causes were comprising of these three, while there are other causes of the death that are pulmonary causes, infections, trauma, suicide, myelodysplastic syndrome, and other unknown causes. This table is describing the differentiation point between the Hodgkin and non-Hodgkin lymphoma. The cell derivation in Hodgkin is B cell mostly, while non-Hodgkin in 90% are B cells, while 10% are T cell. The nodal involvement in Hodgkin is localized and may spread to the contiguous node, while in non-Hodgkin it is disseminated, the nodal spread. The extranodal spread in Hodgkin is uncommon, while it is common in non-Hodgkin type. The bone marrow involvement is uncommon in Hodgkin variety, while the involvement of the bone marrow is common in non-Hodgkins. The Hodgkin is commonly associated with constitutional symptoms, while constitutional symptoms are uncommon in non-Hodgkin tumor. The chromosomal defects, there are frequently aneuploid cells in the Hodgkin variety, but non-Hodgkin tumors are associated with deletions and translocations. The Hodgkin's tumors, they never spill over to the blood, but the non-Hodgkin, they spill over or may spread to the blood. The prognosis for Hodgkin is very good, while the non-Hodgkin tumors have got a bad prognosis. The radiotherapy is the treatment advocated for low-stage localized Hodgkin lymphoma, and but these these radiotherapy may complicate as lung cancer, melanoma, or breast cancer, while the chemotherapy is also used by the alkylating agent, and they can result in secondary tumors such as acute myelogenous leukemia. Recently, the immune checkpoint inhibitors have been used for the treatment of Hodgkin lymphoma, and they basically block the PD-1, the receptor for the PD ligand 1 and PD programmed death ligand 2, and they prevent the CD8 cytotoxic T cell exhaustion that is caused by expression of the PDL2 receptor or PDL2 that is expressed on the Reed-Sternberg cell. So these checkpoint inhibitor uh, inhibit this PD programmed death 1 ligand, and they result in tumor cell destruction. This is the table summarizing the 5 Hodgkin lymphoma varieties, and this table is from Robbins' textbook of pathology. Now for self-assessment, this is a quiz. A 27-year-old man present with an 8-week history of fever, chill, pruritus, night sweats 2 months ago. He experienced a flu-like illness. A nagging cough with occasional hemoptysis persisted for several weeks following resolution of his other symptoms. Physical examination revealed moderately enlarged firm non-tender lymph node located in right supraclavicular region. So what is the appropriate diagnosis? This is Hodgkin lymphoma. Then, which of the following is the most common histological subtype of the disease in this condition? There is presence of Reed-Sternberg cell, and which of these subvariety has got this type of Reed-Sternberg cell? And this is the nodular sclerosis, that is the commonest variety and characterized by presence of lacunar Reed-Sternberg cell. Thank you very much for your attention, and if you have any query, you can email me, or you can also comment below this video if you have any question.